Welcome, everyone, to our final unit on personality psychopathology. Each of us has a unique personality that is a result of our genetic makeup and our life experiences. You may be an introvert or an extrovert, for example. You may tend to be impulsive or perhaps more reserved. Even at birth, we notice differences in temperament and differences in how infants react to outside stimulation. Now, we tend to be rather consistent and predictable in how we respond to situations, but we are also flexible, which helps us to adapt. Shy people are not shy in all situations. It's when these patterns of responding become rigid and inflexible that personality psychopathology emerges. In this unit, we'll look at how clinicians go about identifying and diagnosing personality disorders. Now, this is not an easy task. There are some important diagnostic issues associated with personality disorders. Diagnosis requires longitudinal data and a focus on the long-term course of the disorder. Consequently, more than one interview may be needed. So you have to take a careful history and perhaps even talk to some family members. You need to rule out substance use or another medical condition. As we have learned, substance use can be chronic, and it can be a contributing factor to ongoing relational problems. Countertransference reactions may occur because clients with personality disorders can be difficult. Countertransference refers to the therapist's emotional reaction to the client's behavior. The therapist's unresolved psychological issues may be activated. Individuals with personality disorders can be frustrating and difficult to work with. And we tend to see these people at their worst. They don't seek treatment, or they come to treatment when they're suicidal or in significant distress. Some therapists may not diagnose personality disorders to avoid therapeutic pessimism. And what I'm talking about here is it's commonly believed that these individuals do not get better. But research has shown us that most do get better. The DSM-5 provides a general description of a personality disorder. A personality disorder is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. The key aspects of this definition are incorporated into the diagnostic descriptions for each disorder. There must be a persistent pattern of behavior that deviates from societal expectations. The onset is in adolescence or early adulthood, and it leads to distress or impairment. The essential element of a personality disorder is that it is not an episodic condition in an otherwise well-functioning individual. The prevalence of personality disorders is not entirely clear, and there are a couple of reasons for that. People with personality psychopathology often function well enough and see themselves as not having a problem. Many individuals do not seek help or come to the attention of mental health professionals. Prevalence is difficult to determine, but has been estimated by the text to be 9 to 13% of the general population. The DSM-5 notes that 15% of U.S. adults have at least one personality disorder. Clients are also often misdiagnosed with bipolar disorder due to a highly unstable mood. So because of diagnostic uncertainty, prevalence is difficult to determine exactly. The personality disorders really bring to light the diagnostic uncertainty that exists because of what I'll call a boundary problem. There exists a boundary problem in this category of mental disorders as elsewhere in the DSM, and this problem exists for a couple of reasons. First, personality disorders are complex, and the DSM has described these disorders in ways that lack definitional clarity. Sometimes some very fine distinctions are required, and this can make it difficult for clinicians who need a diagnostic system that is easy to use in the field. And people don't fit neatly into just one diagnostic category, so they are frequently diagnosed with more than one personality disorder. It is difficult to separate personality from personality disorder. In other words, what is considered normal and abnormal. Sometimes we may overlook the possibility of a personality disorder or dismiss it by saying, well, aren't all adolescents just a little borderline? Or isn't everybody narcissistic? And isn't that a good thing in today's society? Looking out for number one? And personality disorders do not respond well to medication and are treated more effectively with psychotherapy. Diagnosis is needed to prescribe a particular medication, and many psychiatrists have a background in medication treatment, but not in psychotherapy. So they'll tend to diagnose a co-occurring mood disorder or an anxiety disorder. Now, taken together, we can see these points suggest that personality disorders can be overlooked. Now, the DSM-5 uses a categorical diagnostic model, which means there are 10 specific personality types, and each is a distinct clinical syndrome. Now, an alternative model has been proposed with components of both dimensional and categorical assessment. Now, this alternative to the categorical system was proposed and rejected. Now, it may be reconsidered in the DSM-6. The dimensional model would use measures of specific personality traits, such as those in McRae and Costa's Big Five: openness, conscientiousness, extroversion, agreeableness, and neuroticism, to give a more individualized personality profile. And remember, it's only when traits significantly interfere with functioning that a personality disorder would be diagnosed. Now, there have been some reasons provided for the old system being retained in the DSM-5. First, most research that has been done has dealt with personality disorders as categories, so previous research might not be as useful. Secondly, more research is needed on the specific dimensions to be used to diagnose personality disorders. And thirdly, clinicians are simply used to the old system, and introducing a dimensional model would complicate matters and interfere with clinical utility. Having overly complex dimensional systems would actually work against recognizing personality disorders. As I just mentioned, the DSM-5 retained the categorical model, which has a clustering system. These three clusters help clinicians and researchers. The 10 diagnoses we'll look at fall under one of the three clusters. Cluster A refers to odd or eccentric behaviors. Cluster B, dramatic, emotional, or erratic behaviors. And cluster C, anxious or fearful behaviors. I created this chart with brief descriptions of each cluster of personality disorders to help you get a sense of the diagnoses under them. As I read them, notice the qualitative differences between the clusters. In cluster A, people with these disorders have symptoms similar to people with schizophrenia, including inappropriate or flat affect, odd thought and speech patterns, and paranoia. Under cluster B, people with these disorders tend to be manipulative, volatile, and uncaring in social relationships. They're prone to impulsive, sometimes violent behaviors that show little regard for their own safety or the safety or needs of others. Individuals with these disorders often appear dramatic, emotional, or erratic. Cluster C, people with these disorders are extremely concerned about being criticized or abandoned by others and thus have dysfunctional relationships with others. Individuals with these disorders often appear anxious or fearful. Now again, the DSM-5 uses a categorical model, which means the clinician assesses and evaluates criteria to determine which personality disorder best fits the client's presentation. Now, if you're interested and have access to the DSM-5, the proposed criteria for trait-specified personality disorders are on page 770 of that book, the DSM-5. Now, we're going to cover the personality disorders by clusters, and I'll be adding some additional information to what is in the text, and you're only responsible for the material that is in the text. Let's begin by looking at Cluster A personality disorders, and they are paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. With paranoid personality disorder, there is a pervasive distrust and suspiciousness of others. Others' motives are interpreted as malevolent. People with this disorder are extremely suspicious of the motives of others and are always on guard against potential danger and harm. They tend to be rigid in thinking. Their view of the world is narrowly focused. They seek to confirm their expectations that others will harm them. Consequently, it is impossible for them to trust even their spouses or their friends. They may seem aloof and lacking emotion, and they use projection as a defense mechanism, as evidenced in a statement like, "I'm not hostile, they are." They're prone to misconstrue innocent comments and minor events as having a hidden or threatening meaning, and they are usually extremely guarded and difficult to get along with, leading to difficulty establishing and maintaining relationships. People diagnosed with this disorder usually only come in contact with clinicians when they are in crisis. They may seek treatment for severe symptoms of depression or anxiety, but often don't feel a need for treatment of paranoia. The next diagnosis in this cluster is schizoid personality disorder, and we'll take a look at some of the characteristics. There is a pervasive detachment from social relationships. Individuals with this disorder prefer to be by themselves rather than with others. They appear to have no desire for acceptance and love, even by their families. There is a restricted range of emotions in interpersonal settings. Others perceive them as cold, reserved, and reclusive. Individuals have a long history of impairment in social functioning. They neither desire nor enjoy close relationships. Sexual involvement with others holds little appeal. The individual is unaware of and insensitive to the feelings of others. Throughout their lives, they seek out situations that involve minimal interaction with others. And finally, it may be associated with a cold, emotionally impoverished childhood. Evidence of the genetic heritability of this disorder is weak, suggesting early environmental influences. The final diagnosis in cluster A is schizotypal personality disorder, characterized by odd, eccentric, or paranoid thoughts and behaviors and poor interpersonal relationships. There are psychotic-like symptoms. Many with this disorder believe they have magical abilities or special powers. Magical thinking is believing you have special powers or magical control over others. There may be thoughts that certain events have a special meaning just for that person, like seeing a TV commercial and thinking that the commercial was just for him or her. There may be suspiciousness and paranoia, such as walking down a crowded street and seeing a group of people laughing and thinking that they're laughing at him or her. There are abnormalities in cognitive processing, and many of these characteristics resemble schizophrenia. Researchers, in fact, see the symptoms as a latent form of schizophrenia, which means these individuals are vulnerable to developing full-blown psychosis if they're exposed to stressors or difficult life circumstances, challenging their ability to stay in contact with reality. And few of these individuals actually seek therapy. Cluster B in the DSM-5 has 4 diagnoses: antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. Cluster B often involves dramatic, emotional, or erratic behavior. Antisocial personality disorder has also been referred to as sociopathic or psychopathic. It is very common in forensic or criminal settings. There is a pervasive pattern of disregard for and violation of the rights of others, and this must have occurred since age 15. Researchers have found that childhood onset as a conduct disorder is common. Now, this disorder is also characterized by deceitfulness, callousness, and hostility. You may find individuals were repeatedly fired from jobs for arguing with their bosses or becoming aggressive with customers. There's a lack of anxiety and guilt over failure to conform to social or legal codes. Individuals with this disorder are highly impulsive and they lack remorse or regret for their actions. These individuals seek power over others, and this diagnosis applies to individuals age 18 or older. The diagnosis cannot be given to someone under 18. And it's difficult to treat. The very characteristics of this disorder lead to poor outcomes. Treatment is difficult because of the long-standing behavior patterns that are difficult to change. And these individuals are unlikely to voluntarily seek treatment. Finally, clinicians have difficulty telling when their client is being sincere or being a smooth talker. Also under cluster B is borderline personality disorder. The term borderline relates to its origins in the 1930s as a condition on the border of neurosis and psychosis, on the edge of schizophrenia. It's characterized by an enduring pattern of volatile emotional reactions. You'll see unstable interpersonal relationships, a poor self-image, impulsive responding, intense mood fluctuations. The person may engage in behaviors with negative consequences, and there are also poor coping skills. People with this disorder go beyond feeling insecure. They literally rely on other people to make them feel whole. A sense of emptiness drives these individuals to seek the reassurance and closeness of others, but they're so intense that it drives others away. As a result, their disturbed feelings become more intense and they become more demanding, moody, and reckless. Now, splitting is a term used to describe how people with BPD relate to others. A black and white dichotomy occurs. The preoccupation with feelings of love for another can quickly turn to extreme rage and hatred when they are rejected. These individuals may say, I love you, I hate you, in the same sentence. Suicidal attempts and gestures are very common. Self-mutilation is also very common. The treatment of greatest demonstrated effectiveness is dialectical behavior therapy. BPD is the most commonly diagnosed personality disorder. Prevalence ranges from 1.6 to 5.9%, and it is more common in women. And this is important. Up to 10% of those with BPD die by suicide, so this must be closely monitored and assessed during treatment. The intense despair which individuals may experience may lead to suicidal gestures, either as a way to gain attention or to address threats of separation or rejection by others. A number of biological factors have been found, including high heritability and abnormalities in the amygdala and prefrontal cortex, areas of the brain involved in emotional processing and emotion regulation. Understanding psychological processes involved in emotion regulation has led to better treatment approaches, as in dialectical behavior therapy, where clients are confronted about their problematic behavior, and through using a process called core mindfulness, clinicians teach clients to balance emotions, reason, and intuition. Also under cluster B is histrionic personality disorder, characterized by a pervasive pattern of excessive emotionality and attention seeking. This diagnosis is characterized by drama. These individuals talk a lot and they are inappropriate. They manipulate for attention. People diagnosed with this disorder show extreme pleasure with being the center of attention and behave in whatever way necessary to ensure this happens. They are excessively concerned with their physical appearance, often drawing attention to themselves in ways that seem ludicrous in the way they dress and carry themselves. People often perceive them as flirtatious and seductive. And individuals demand reassurance, praise, and approval of others. Another characteristic is wanting immediate gratification of their wishes and overreacting to minor provocations, usually in an exaggerated way, such as by weeping or fainting. Although their relationships are superficial, they assume they are intimate and refer to their acquaintances as dear friends. And they express strong opinions with dramatic flair, but their speech lacks detail and it is superficial or impressionistic. He or she may say someone is a wonderful person, but they cannot give you specific examples or details to explain why. The final diagnosis in this cluster is narcissistic personality disorder. Now, this one was going to be dropped from the list, but the DSM-5 work group decided to keep it in. There isn't much research on this disorder, but it is distinctive, and clinicians felt it was a useful diagnosis. Plus, I think narcissists would be upset if this diagnosis was dropped. They hate to be ignored. Some of the characteristics of this disorder include basing self-esteem excessively on the views of other people. This leads to problems or impairments in goal setting, as their goals are often set too high to impress and to gain approval from other people. These individuals see themselves as exceptional, and they have a strong sense of entitlement. Also, grandiosity may mask an underlying vulnerability in sense of self. They may be more sensitive to rejection and bolster their fragile egos by making up grandiose goals and fantasies. And there's an old therapist joke, how many narcissists does it take to change a light bulb? Just one, to hold the light bulb while the world revolves around him. Cluster C is a set of disorders that involve people who appear anxious and fearful. They tend to be inner directed and may draw little attention to themselves. This chronic sense of anxiety leads to behaviors designed to avoid feared situations. The diagnoses are avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. Let's move on to dependent personality disorder, characterized by a pervasive, excessive need to be taken care of. This leads to submissive and clinging behavior. Individuals have a fear of separation, and there's a high risk for becoming a victim of relationship violence. These individuals are strongly drawn to others. However, they are so clingy and passive that they achieve the opposite of their desire to be close, as others become impatient with their lack of independence. Convinced of their inadequacy, they cannot even make simple, trivial decisions like what to wear on their own. They cannot initiate new activities on their own because they feel they will make mistakes unless someone guides them. And when they are alone, they feel despondent and abandoned. Consequently, research has shown that this diagnosis is associated with overprotective authoritarian parenting. It is a relatively rare disorder. In clinical settings, more women than men are diagnosed with this disorder, and unlike other personality disorders, individuals with this disorder frequently do seek treatment. I'm going to conclude this presentation with a look at the final diagnosis in Cluster C, obsessive compulsive personality disorder. It's characterized by a pervasive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control. These individuals define their self-worth in terms of work productivity, for example. These individuals are not looking for approval for their work accomplishments, but they throw themselves into their work at the exclusion of social relationships. Although self-control, perfectionism, attention to detail, and perseverance are highly valued in many societies, these individuals carry these traits to an extreme. Now, this differs from OCD, which we studied earlier in the course. OCD involves unwanted intrusive thoughts and urges. Individuals with OCPD see their way of functioning as correct. This disorder is a more generalized way of interacting with the world. OCD, again, is distinguished by the presence of obsessions and compulsions. Individuals with this disorder often appear grim, intensely in control of their emotions, and lacking in spontaneity. Following rules and procedures becomes time-consuming, and they may have occupational difficulties because of this. And when they need to be flexible, they have a lot of difficulty. They tend to have abnormally high standards, which leads to being unproductive. The pursuit of perfectionism becomes self-defeating rather than constructive.